Okay. Well, welcome everyone. My name is Dr. Kevin Lombardi. I'm a medical doctor and epidemiologist and currently serve as the manager of health research, policy, and advocacy at the National Center for Health and Public Housing. Today, I'll be giving several different perspectives of the social determinants of health. This LC is designed to give a firm understanding of the SDOH. Within the context of this LC. This will serve as the foundation of the LC and our subsequent discussions as we delve deeper into the literature and deeper into the evidence that supports SDOH policy use within the clinical context. There will be discussion and case studies involved today. These are designed to impart a perspective of the SDOH and to impact SDOH policies on patient care, staff retention, and health center management. Throughout this, we'll be recommending participation as much as you are willing to give it. A good predictor of how much you will take from this LC will be participation in these. I designed the curriculum around the discussion questions. But I think it's important to recognize that the SDOH is a complex, difficult, and highly personal topic. I believe the discussion is an important part of increasing our understanding of the SDOH and in turning policies into reality. To summarize, today we'll perform a general conceptual overview, investigate the impact of SDOH on health center management, and discuss the benefits of awareness of the SDOH on patient care and health center service delivery. And I will pass off to my colleague, Fide, who will start the session.
All right, thank you so much, Kevin, for that very nice introduction. My name is Fide Pineda Sandoval, and I am the TTA manager here at NCHPH. And today I will be helping facilitate the session. And we also have with us our communications manager, who is Chantel Moore, who will also be providing us support on any technical or logistical issues that we may have. So first, this is just a kind reminder that all participants are muted upon entry. Please make sure that your line is unmute. That way we don't have any interruptions during the presentation today. Also, if you have any questions or any concerns or any promising practices that you would also like to share with us today, you can do so by entering it during the chat, or also raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and the link will be sent via email to all participants after today's session. All right, so before we continue, the mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is also a project supported by the Health Resources and Services Administration and is a national training technical assistance partner that is 100% financed by this grant, and the information presented today are those of the author only. All right, and then here we have some background information about health centers that are close to public housing. Here we display data that contains information on patients that are served by federally qualified health centers. As of 2021 UDS data, there were over 1,000 FQHCs that served to 30 million patients, 458 FQHCs that were in or immediately accessible to public housing that served to 5.7 million patients, and 108 public housing primary care grantees that serve to over 900,000 patients as well. And then here we have some data that describes the demographics of residents of public housing. As it is displayed, the 1.5 million residents demonstrated characteristics that differentiate them from the general US population. There were also 2 persons per household, and 32% of residents. Excuse me. So I'm going to ask very kindly for everybody to mute their line. That way we don't have any interruptions. Thank you. And then I'm going to continue here. So as of 2021 data, there were 2 persons per household as well, 38% that were disabled, 52% that were white, and 91% that were low income, 43% that were African American, 26% that were Latinx, 19% that were elderly, and 36% that were children in public housing. All right, now I will pass it on to Dr. Kevin Lombardi.
All right, everyone, just to go over our session content objectives, there's a lot to go over today, and we may not get all of it, but here's what I have planned to go over. One, we're going to present and discuss the SDOH as an epidemiological framework, a way of understanding patient care and healthcare management. Two, we'll review key research regarding the implementation of SDOH policies, protocols, with a particular emphasis on the how and the why. Three, we'll examine the implications of the SDOH framework on clinical practice and workforce management. Four, we'll examine frameworks for implementation of SDOH policies and protocols. Next, please. Okay, to start with the social determinants of health, and just to briefly to explain the slides, the resources that are reviewed in each slide will be at the bottom left in a link. I encourage you all to check the links and to read the papers at your own leisure if you're interested in them and the particular details they go over. I will be going briefly over all of these, and there's a great deal of information in these publications that you might find valuable. The social determinants of health are defined as the conditions in which people are born, grow, work, live, age, and the wider set of forces and systems shaping the conditions of daily life. These are responsible for most health inequities. Social determinants are primarily rooted in resource allocation and the decisions made around resource allocation, and they affect factors at the local, national, and global levels at the same time. The SDOH interplay with biological factors such as disease status, risk of disease development, and behavior to impact patients in a myriad of ways, with particularly negative health impacts having been measured in the socioeconomically vulnerable populations throughout our country. The United States, despite ranking among the 10 richest countries in per capita income, experiences sizable health disparities among its citizens that are rooted in these factors. In the US, on average, there's a 15-year difference in life expectancy between the most advantaged and disadvantaged citizens. This is proportionately much larger than other countries with similar levels of GDP per capita. This difference is correlated with geographic characteristics and health behaviors that have negative impacts on patients. They're influenced by historical and social factors in this country, such as segregation, classism, and xenophobia. The cost of these discrepancies is significant. Population level inequalities in healthcare result in $309 billion in losses to the economy annually and disproportionately affect disadvantaged populations throughout our country. Social mobility is also an important aspect of these structural inequalities. The lack of economic or social mobility can affect future generations who are born into environments that contributed negative health outcomes. Research also consistently demonstrates that investments in interventions to address the social determinants of health, such as housing, income support, and care coordination, yield positive outcomes consistently. Next slide, please. Please take 3 minutes to consider the following question with the following prompt. There have been a variety of studies that have indicated that addressing the SDOH at one's institution through policies or protocols positively impacts the working lives of those that have those jobs. What I'd like to do now is for us to spend a moment and think about what those positive impacts are and how they affect our workflow. How is addressing the SDOH at your institution positively impacted the working lives of you and your staff and colleagues? I'll ask that you please write or type your response and be prepared to share. And that will be, let's go for 3 minutes. I will start a timer. Thank you. Oh yes, and I will say, for those of you who are less inclined to share with things with us verbally, please make use of the chat. I will read your response, ask you questions, and if you're not interested in speaking, discuss the implications. We are at 1 minute and 30 seconds. That is halfway. Thank you for those of you who are using the chat. I appreciate your responses and level of detail. Okay, we're just over 2 minutes, just a little bit of time remaining. Okay, before we raise hands, I wanted to share my own experience with this. I first experienced burnout related to the social determinants of health and my ability to act and create change in my patients' lives in social determinants of health and related fields when I was in medical school. That's something that I experienced throughout residency as well, and something that got worse as I spent more time with patients as the COVID-19 pandemic applied other pressures to patients as well. My experience has been at institutions where the social determinants of health is integrated into workflow that my experience has been better and the experience of my colleagues has been better. I've read that in the literature as well later on in my career, and that's the inspiration for this question, is that we often don't reflect on the way that these policies that are designed for our patients affect us positively as well. And that positive impact has a very real impact on workforce retention. People who are happier do better at their jobs, and patients do better when their clinicians are happier. So I think we'll start by raising hands if anyone would like to verbally share something, and with an understanding that we have individuals of all levels of health center work and management here. Are there any hands?
Okay, I do see a hand raised.
If you could do the calls, please, Fide, and there are no time limits, so please, but please keep in mind that we do have a long session, so we would appreciate the details, though.
For sure.
Yes.
All right, so I'm gonna unmute the line for Nesreen Gooseby. Hopefully I said the name right.
Yes, could you correct us, please, if that was incorrect?
Mhm.
Yes. Hi, my name is George Yagatic. I actually had the wrong name typed.
Oh, okay.
I just wanted to share that our health clinic here in Visalia, California, has initiated two very popular and I feel important initiatives. One is transportation. We do know that 30% of our patients have identified as transportation as their number one issue with regard to receiving their health care. So we have designated staff who do provide that transportation to our clinic for health services, also to referrals and to other services related to their health care. So that's been a big part of the work that we're doing here, and we found a very strong positive response to that in terms of bringing the people most in need of in our community to the services we offer. The other initiative that we have undertaken is to provide a fresh produce farmers market at our clinic on a regular basis. So we get a donation of fresh produce, and we provide that for our patients on a specific day on a regular basis. And we have had a very strong response. Patients have been calling in for that, asking, what day are we giving out produce? There are a number of organizations around the country that offer donations, and it was fairly straightforward and simple to set up. And it's just been a real benefit for our not only our patients, but our clinic as well.
I really appreciate you sharing that, George. If you don't mind, I have a few questions for you. I appreciate the details about your program, and it seems that you picked two large priority areas that were identified as issues with your community. I was wondering if you could please, one, tell us a little bit about your community and what it looks like. And two, why was transportation and food access the areas where you chose to grow your programs? Was an issue of resource availability, of expressed needs, and if so, how did you guys hear that?
Thank you for asking, Kevin. I think those are really good questions. And without the time to prepare, we do have those demographics as well as the data for why we gravitated toward those two issues. I think consistently in different surveys that you can find, those two areas are very much in need. As I quoted the stat of 30% of our population did identify transportation as the number one hurdle to receiving health care. And I think, as we all know, the cost of food nowadays is tremendous and really cuts into the amount of money that people have to spend. So again, those two areas, those two social determinant of health areas, we felt were outside of housing, really our biggest areas to kind of make a dent in. Visalia, California is a urban city in the Central Valley of California. We are a farming community. We have a large Hispanic population, and the patients at our clinic are generally Medi-Cal and Spanish speaking, and so because of our population and those identified needs, that's the direction we went.
Well, I find this process that you described very interesting, in that you have clear ways to understand what the needs are, and it's obvious that you've grounded your initiatives very firmly into the literature. So thank you so much for sharing that. Thank you for that. And Fide, if you could pick another hand if we have them.
Sure. All right, so at this moment, we do not have any other hands raised,
Mhm.
but I can pick a volunteer.
If we do not have hands raised, considering the time, Fide, I'm going to address the chat if you don't mind.
Okay,
But if we do have them, please, folks, do not be shy. Um, I'm looking over what I'm seeing, and I think this speaks to the level of intimacy that our audience has with this concept in their daily work. But what I am seeing is a real focus on how this really impacts staff in a very real way. And I think that speaks to the burnout and the importance of integrating these policies specifically, not just for the patient, but for our holistic health as a system. The SDOH principles allow us to kind of break down the borders that are often placed between individual and community health. These borders are, of course, artificial and are based on how we perform and do medicine in the United States. That framework allows us to see it more holistically while maintaining that framework. And it's very clear that the impact on the workforce is understood here. So thank you for that, and thank you for sharing. If we could go to the next slide, please, we're going to talk more about the individual details of how the SDOH affects patients. So again, this is from the Kaiser Foundation. They have a very nice report on their effort to integrate the social determinants of health into their very holistic model of community medicine. For those of you who have worked with the Kaiser Foundation or who are interested in how their models are financially viable and successful, I'd recommend reading the report. But for the purposes of this lecture, I'd like to talk about how the SDOH impact people's lives from a patient care perspective and that of the patient themselves. Conceptually, the SDOH interplay with biological factors, disease status, and behavior to impact a myriad of health outcomes, with particularly negative health impacts in the socioeconomically vulnerable populations. And I will say that this is a fact that I knew prior to clinical practice, but that I didn't really understand. So I'm hoping imparting that perspective can help all of us to raise our collective understanding of how this really impacts patients on a real and personal level. The presence of these dynamics, and by that I mean the SDOH and related factors, and particularly the stressors that are associated with them. Stressors like things that many of us can relate to: being late on rent, fearing eviction or court action, fearing unemployment or hunger, fear of not being able to care for your children or family. The anxiety related to these raise the risk of poor mental health outcomes significantly. These outcomes include anxiety, depressions, and various psychosomatic pain syndromes and exacerbation of existing physical pain. These things hurt people, and they hurt them in very real ways that impact their medical conditions significantly. These conditions raise the risk of developing or exacerbating existing chronic illnesses and lead to overall increase in poor health outcomes. And for those of you who are involved in clinical care or practice management, I don't think I need to tell you how very serious type 2 diabetes, hypertension, and heart failure is in our communities. Those are conditions that very intimately respond to the body's response to stress in a very real way that makes outcomes worse, plain and simple. When I think of these things and their impact on patients, I like to use the percent risk model, as if someone is exposed to influences that increase their level of anxiety, like the ones I just mentioned, it raises the risk that they will develop one of these conditions or that they will experience an exacerbation of these conditions. For those of you who work in the emergency room or urgent care, a common thing that you'll see in your communities is hypertension, uncontrolled hypertension, illnesses associated with high blood pressure, illnesses associated with type 2 diabetes, such as kidney failure and so forth. We can see these conditions as developing because of a constellation of symptoms over time. The social determinants of health helps us to understand an aspect of that that's difficult to treat through medical care alone. And as a physician, I find it particularly valuable when understanding the real life experiences of my patient and what my limitations are in being able to help them. Next slide, please. I like this graphic because it gives a good example of connecting these factors, which are population level things, right? Education, job status, family support, and so forth. These are things that we all experience on a population level, but they have very real individual implications on our health, as we've all experienced in our own lives. So let's review the contribution of these non-clinical factors on individual health. Differentiating the impact of the SDOH on individual and population health is important for understanding how it really affects populations. The SDOH is a powerful concept because it can be applied to a number of different aspects of patient care and population health. When applied to individual health, the SDOH helps us to understand the impact of stressors related to health and housing on the body. And that perspective is something that we bring into the exam room, into the case management room, into the program development and boardroom, and so forth. We take care of real people, and oftentimes our jobs focus on tasks that are less involved with the real people than we would like to. That removal requires us to refresh our understanding of what their experiences are. When I'm practicing clinically, that's something I do every day as a part of my preparation for work. And it's important for us to understand that the individual health and the population health, although they are separate in a managerial and a practice standpoint, they combine when the patient leaves the exam room, and it's the reality of their lives. So for those of you who will be or are interested in creating resources for your own staff education on SDOH, a link to this resource will show a number of different graphics like this that help to really get an understanding of how the SDOH impacts a person's real health. Just to take a couple of these job status, and I'll talk about the research and how it really affects patients. We look at the top, we look at education, job status. These are things that studies have consistently linked to overall mental well-being. That's been linked also to better access to key resources, infrastructure, and information related to health and housing. I think it's easy to imagine how better access to those things reduces anxiety and a number of other physical complaints that impact people's health. And the physical environment. And the important thing with the physical environment isn't just safe neighborhoods, but neighborhoods that are perceived to be safe by the patient and person. These results in lower rates of anxiety, less exposure to pollution, more freedom of movement, and better feelings of self-determination, all of which have been consistently linked in studies and interdisciplinary studies as well to better overall well-being. Next, please. Okay, we are at the halfway point now of our first session, and we'll be starting our first case study. I'll be integrating case studies into each of our sessions as a way for us to, one, understand our own different perspectives and the different pieces of the FQHC and housing spectrum that we all work in. Two, to understand that patient care is complex and there are a variety of us that have different roles in it. But really to understand how the SDOH often manifests in the exam room by looking at key examples and making connections to our own workforce and SDOH programs. Fide, would you mind reading the study for me, please?
Yep. All right, so Ms. Torres is a 45-year-old female who presents to her primary care office with complaints of chest pain, fatigue, and general malaise. Vitals indicate a heart rate of 75 beats per minute, blood pressure of 170/85. Physical exam is unremarkable aside from slight shaking of the hands and feet while sitting. When interviewed, Ms. Torres reports that she often feels short of breath, dizzy, and experiences pain in the center of her chest. She reports these symptoms occur 2 to 3 times per week for the past 6 months. She has a PMH significant for depression, type 2 diabetes, and hypertension.
My apologies for the acronyms, Fide. Could we go to the next slide, please? please take 30 seconds and read the case to yourself. Thank you. Okay, so here I highlighted the key things that catch the eye of the clinician when looking at a case like this. We have a 45-year-old female, and she's coming to us because she's having chest pain, fatigue, and general malaise. And for those of you who work in the exam room or support patient care, you may be aware that those are very non-specific symptoms, and there's a variety of conditions that can manifest that way. The vitals indicate that this is someone that has hypertension and is experiencing tachycardia. The physical exam, though, is largely fine, aside from the shaking. Shaking can manifest in patients for a variety of reasons, though, so that is also a somewhat nondescript symptom. However, when interviewed, Mrs. Torres tells us a lot about the symptoms here. She has a shorter breath, she's dizzy, and she's having pain in the center of her chest. She reports these symptoms occur 2 to 3 times per week in the past 6 months. That's the sentence that tells me a lot as far as what my possible diagnoses are, what I need to rule out, and it's starting to give me some answers to the questions that I need to ask Mrs. Torres, or some direction to the questions I need to ask her about what's causing those symptoms. The past medical history here is significant as well. Mrs. Torres has a history of depression, type 2 diabetes, and hypertension. These are very dangerous chronic medical diseases, which I am concerned as the clinician may be exacerbated by her current symptoms. Would anyone like to share either the community health worker, case manager, nurse, support staff, administrator, or social work perspective of this patient? In particular, if you have anything that comes to mind about your own job and management of similar patients that you'd like to share or guide us on. And Fide, just keep an eye out if any hands are up.
Mm-hmm. Yep.
All right, let me know if they pop up. Next slide, please. So continuation of the case study. When Mrs. Torres, excuse the typo, is experiencing symptoms concerning for experiencing symptoms concerning for anxiety and PTSD. When questioned further regarding the stressors in her life, she mentions the following. She and her husband get limited hours at their job. As a result, they're behind on bills. Her family, which includes Mrs. Torres, her husband, and 2 children, a boy aged 4 years old and a girl aged 7 years old, have been threatened with eviction on several occasions in the past and are concerned that it may happen again soon. Mrs. Torres undergoes a full cardiovascular assessment that is largely unremarkable. All of her labs are within normal limits, and her EKG is just present for sinus tachycardia. Next, please. So I'd like us to take 5 minutes to think about Mrs. Torres, her experience, and the following questions. You can answer all, or just 1 or 2, or any that appeal to you. But I'd like you to at least spend time thinking about each of them. 1, how do the stressors in Mrs. Torres' life impact her physical symptoms? 2, what are some ways that Mrs. Torres and her family can be networked to resources which can reduce her anxiety and improve overall well-being? 3, what are the implications of not networking Mrs. Torres to services? And that can be for both staff and patient. I'll ask that you please write or type your responses, and feel free to use the chat. I will be asking for hands in 5 minutes. The timer has started. Thank you for your time and consideration of these questions.
Okay, I'll go ahead and show the previous slide in the meantime.
I've placed my email into the chat. For those of you who'd like a detailed review of their response and personalized comments to their response, please email them to me and I'll do that within 24 hours.
Would you like for me to read some of the responses, Kevin, in the meantime?
Fide, if we could slowly rotate between the two slides so that folks see the details and give them the full 5 minutes to consider the question, I'd appreciate that.
Sounds good. All right, so here we are at the beginning of the case study.
Okay, Fide, we're at 3 minutes, and I think we're going to go ahead and for the sake of our the rest of our lecture, continue. I'm seeing a number of responses in our comments that I'm personally interested to hear more of what that individual has to say. I will call you, and if you'd like to share, please respond. Crystal Pascal sent to us the following. Mental health has an impact on the overall body. Due to the stressors in her life, it has impacted her physically and mentally. Mrs. Torres cannot focus because she is worried her and her kids will be put on the streets, which leads to certain reactions in her body reacting to stress. So thank you for sharing that. I agree. I think you're right on. I was wondering if there was anything else you'd like to share with us about that.
Hello.
Yes. May I
Yes.
call you
Hey.
Crystal?
Hey, how are you?
Well, Crystal, do you have anything else to share with us? I was struck by your response and would love to hear more.
There was a certain word, I can't find the name of it, which I was told a while back, certain elements in the body releases some type of thing that causes stress, which leads to other health deteriorations. And if when you can't, you have to be healthy yourself in order to serve others and focus. Your main goal has to be to take care of your body before you can help and service to others. Because if you don't take care of yourself first, who will then? You're worried about who's going to be able to take care of your kids in the long run, being put out on the streets, which can lead to other factors such as defects and all other types of things taking place.
Thank you for that. I agree that we're witnessing an individual that is going through a great deal of self-sacrifice to take care of and protect her family, and in many ways suffering physically because of that. But Crystal, you mentioned a couple of things that I think are worth highlighting. One, you mentioned the very real physical effect these things have on our body. And I say physical because there are very real endocrine pathways in our body that respond chemically to these stressors and exacerbate conditions such as hypertension, high cholesterol, and so forth that are related to bad outcomes. How can we expect as clinicians, as folks that are working at FQHCs in support of patient care to help patients if we can't help them with key areas? And I think this connects back to the frustration many of us feel and the motivation that all of us feel to make sure these are priorities, that these policies are priorities. So thank you for sharing that.
You're welcome.
Rebecca, I see that you mentioned that stressors are causing anxiety, which is leading to her physical discomfort that makes her think that she has a heart condition. So just to speak briefly on that, I agree. And would you like to share more about that before I give the physician perspective?
I would say this seems like a case which we are all too familiar with. We have to help them network into other areas, such as finding assistance with rental assistance, putting them in touch with an employment agency that they may be able to find them better income with more hours. We often have to actually go out and find medical care. We often have to tell them about Medicaid being available for their children. We have a program here called LIHEAP, which is run by our electric company and helps with electric bills. We have several agencies that we network with because we find that in order to help with people's health, we have to look at the whole person and not just one area of what's affecting them. So we do have a network of social agencies that we can communicate with and put our clients in touch with.
You know, when I hear this, Rebecca, it's clear that there's a focus on the person-centered model at your institution. And I'm suspecting that you may be personally involved in social worker case management in some ways. I was wondering if you could answer that, if you are.
Okay, well, I'm Wendy anyway. I'm Rebecca. Hi. I'm the one that's been doing the typing. We're community health workers, and it's our job to educate our clients. In educating them and advocating for them and coordinating care, it's necessary. We're kind of spread thin because we work with them in so many areas. We are both involved in providing them with assistance through the barriers to healthcare, but in order to be healthy, you also have to have a good socioeconomic position, and that's pretty difficult sometimes when people hear, like, we live in a rural community that's all agriculture and beef cattle. A lot of our people are Hispanic and don't even understand the system. They just migrate from one place to another and don't even have a clue. So we educate them on what's available. We lead them sometimes by the hand and make sure that they get the care that they need. I mean, quality of life is a very important part of health. So we're pretty well-rounded in our resources. One of our biggest problems here is that we do have a lack of transportation. And we're trying to work on overcoming that in some way or another. But as I said, there's language barriers, there are transportation barriers, financial barriers, and we just try to help them all bring everything together so that it works for them.
Well, firstly, thank you for your service. Community health workers are the foundation of the policies that actually make this work. Where we've seen the best research come out in actually making these programs into reality is with the use of community health workers. So thank you for that. And we are all hoping for community health workers to be more appropriately reimbursed by Medicare and Medicaid for their services. And I believe that's change is happening. So thank you for your service, and be excited for, I think, an exciting future for community health workers. You said a couple of things that I thought were very interesting. One, it's very clear that the person-centered model is a big part of what you do. But I'm hearing things that are in some ways similar to other rural communities throughout the United States with regards to transportation and with working with migrants and immigrants from other countries and parts of the country. Historically speaking, the infrastructure for accepting immigrants is mostly in large cities. This infrastructure in some cases is significant as folks have to adapt to new languages, new systems, and so forth. I've worked extensively with physicians from Latin America, and my experience has been that their health systems are entirely different than ours. And in many cases, when you can imagine the position of an immigrant, they have to learn a language and a health system, and we happen to have one of the more complex health systems in the world. So I appreciate you all for focusing on that challenge, and I think it's important to note that that these SDOH policies and improvement of the patient-centered model, they help everyone, and in rural communities in particular. Making sure that the transportation and immigrants are appropriately cared for is a consistent challenge and one that requires a lot of thought and time to address appropriately. So thank you for that and for that detail. Fide, are we seeing any hands up before I transition?
Nope, no hands have been raised.
So just taking time to look over, due to time, I can't go through all of these, but what I will say is I appreciate the focus on the patient-centered model and the understanding of how deeply these things are associated. So thank you all for sharing and for your service to these patients. If we could go to the next slide, please. Okay, as I suspected, we will be running a little bit short on time today. So I'm going to briefly go through a number of subjects, which we will go into more detail further in this LC. I wanted to start with the WHO conceptual framework. This is for those of you who are really interested in the overarching themes of the SDOH and what the recommendations are at policy level. I would highly recommend pulling up this document, printing it out, putting it on your desk, and having it with your coffee in the morning. That's how I did it, and I personally found it an enjoyable read and very detailed. The language is a bit heavy and it takes time to read, but if you have a pen and pencil and you circle things and you make notes like I do, the concepts really help to coalesce in one's mind. And the framework is very detailed and has a variety of recommendations, but I'd like to boil it down to really the main concept that the WHO uses. In this framework, the SDOH are essentially part of a continuum, and they're based on, as a foundation, our concepts of universal human rights. These are universal human rights that are associated with treaties and international meetings and developments that leaders of our country have signed off on. And these are things that are important to us, of course, as clinical professionals and those who support the clinical care of patients through social work and other aspects of care. But the essential recommendations are at the policy choices be based on those universal human rights, and that those lead to more equitable outcomes. Now, these may seem like obvious conclusions for those of you who are involved. The important thing is the research, data, thought, and time that goes into each of these concepts and the conceptual framework. So for those of you who are interested and would like to get the details, I recommend bringing that report up and printing it out. But at the very least, an understanding of SDOH is growing naturally out of universal human rights and being pushed primarily by the policy choices that we make. Now, when I'm talking about policy, I don't mean just government policy. I think that term tends to be used somewhat exclusively for that. When I mean policy, I mean government policy, but also local, state, and health center policy. In many ways, the local, state, and health center policies impact SDOH far more than national and international policies, because you are the folks that actually do things. In order to impart this change and to improve awareness of SDOH and to experience its benefits, those policies need to be present at the health center level. What we will be going through next week is the processes required to get there. There are a couple of steps that are involved in that, but we will be focused on one, understanding of how the policies bring real changes and real benefits to our staff and our patients according with the data is. In order to promote the policies, we need to have a good understanding of what the research is, because health center management is data-driven, and that data empowers us to make positive change. So we'll be going over that, and there will be links to all of the resources that you can print out and involved in your own studies, work with colleagues, and hopefully empowerment of yourself and colleagues to create these policies at your own center and support your center in its existing policies as well. So what I will say is I have been hearing about the SDOH and its implications as a clinician for about 15 years now. Before I was in medical school, it was a radical concept. It was a radical concept and one that we did not talk about in many contexts because it was so radical. What we are finding now is that through better education about what the SDOH really means practically on the ground, health center managers, clinicians, and folks that are involved directly in patient care are starting to see the SDOH as how it really is, which is a framework for improving community health and improving our organizations. We'll be going through the data and the details that help us to construct that argument, so as to improve our own understanding and to engage in the concepts, and also to improve ourselves in our institutions. So I'm very looking forward to hearing those of you who have things to share in our future sessions. And I want to go, before we close, to the second to last slide, if you don't mind, Fide. Spoiler alert on these slides. I'll change the images. Surprise you.
Let me know where to stop.
Part of all the way to the bottom, Fide, and I'll tell you where to go. Part of enjoying the subject you're teaching on is you often put way more than you need onto your slides. Okay, stop. Up one, please. Mm-hmm. Sorry, down one. Thank you. Fide shows consistent patience with working with my wandering mind. Thank you. So I'd like to ask all of you to please contact us if you're interested in any of the following subjects: and improving access to legal services through patient-centered delivery models, integrating the SDOH into health center management and workflow, and the impact of the SDOH on FQHC worker retention. We have active collaborations with HUD, the Health Resources and Service Administration, the Milken Institute of Public Health, Legal Services Corporation, and the National Center for Medical Legal Partnerships to support initiatives in this field, and we would like to leverage those to promote health center development and promotion. If anyone is interested in talking about these subjects and finding places where we can help our patients and help our centers, or places where the National Center for Health and Public Housing can help to promote your efforts, please do not hesitate to reach out to me. Thank you so much for your time. And is there a questions slide after this, Fide?
Yeah, so we have a few, just the Q&A session slide, and also, I'd like to remind everybody of our next session. That is next Wednesday, June 7th at 1 p.m. Eastern Daytime. Time. And you will be using the same registration link that you used today for that session as well. And we also received a question here if the presentation slides will be shared. Yes, they're going to be sent to everybody after the session today.
They can be shared and they can be shared internally within your organization as well. Please don't be shy. Anyone who you think can benefit from the publications or materials on the slide is welcome to receive it. Do we have any questions, concerns, thoughts, or contributions that anyone would like to say before we close? I will be staying post closure for anyone who would like to speak in a more private setting.
All right, so in the meantime, will we have any questions coming in or anything else? Just wanted to remind everybody to please complete our post-evaluation survey also. And the link has been provided by Chantel in the chat. Your feedback will be greatly appreciated.
Lucinda Bazil, thank you so much. I'm very happy to have you here to do this journey with us. The world is changing and our medical system is changing very quickly. And what's very clear to me is the SDOH is going to be a very big part of our lives going forward. So appreciative of your service to our patients, to our communities, and leaving this with an understanding that you are the folks that are getting things done, and we are very appreciative for everything you've shared with us today. If you go to the email slide so they can see our contacts, please. Here is myself and colleagues. You can reach me at kevinlombardi@namgt.com. You can reach Fide.
Hi, yes, you can reach me at fide@namgt.com. And also you can reach out to our communication specialist if you have any questions about the recordings or the slides to see more at namgt.com.
Just one more mention for those of you who have large Spanish-speaking community health worker forces or who manage or provide programs in Spanish language. We provide consulting and guiding services for free for our health center partners in Spanish, led by Dr. Jose Leon and Fide. Please reach out for us. It's a field that we're interested in helping you promote. Thank you so much. Have a great day. And I'm so looking forward to our next session. I will be staying on. If someone would like to speak with me, please message me directly. And for the rest of you, have a good day. My camera will be off, but I will be present and listening. Fide, I'll call you in approximately 10 minutes if that's okay.
Yep, that is fine.
Thank you.
You're welcome. Thank you, everybody.